Okay, good afternoon, colleagues, and thank you for joining the COVID update meeting this afternoon with Public Health Birmingham, Dr. Medipe Amanuju. Hopefully, we should be having Dr. Okunku on the call as well to give us a vaccine update. Our usual housekeeping, please do keep your mics on mute unless you need to speak. You do use the chat function to ask questions or make comments. You can also use that to indicate that you'd like to voice a question. You can also use the hands up icon. The call is being recorded for minutes purposes only and will be shared with members of this group, and it's not for the public domain. We've also got a colleague from suicide prevention team from Solihull Bissell. Yeah, RT, she'll introduce herself, she's on the agenda, and I've posted the agenda in the group chat as well. So first item on the agenda is straight to the COVID update from Medipe. And Medipe, just give us a tick and I'll start sharing the screen.
Yes, please, Habib. Thank you.
You're welcome. There you are. Can everybody see the screen? Yeah, you can see the slide. Over to you, Medipe.
Thank you. And thank you to everyone for coming along. It's a nice sunny day. We all want to be out in the sun enjoying the lovely weather we're having. Whilst the weather is still nice, we'll make the most of it. And as usual, we'll give the COVID update. And if Dr. Okonkwo doesn't make it before the end of this, Habib, I'm happy to do an update on the vaccination based on last week's data.
Sure. I'll bring that slide up as well, Medipe.
Thank you.
Me too, yeah.
Yeah, so thank you to everyone. The rates of infection continue to drop, as you can see on this particular slide, which gives us an overview of the infection rates of a week up until the end of last Friday, 3rd of September. This is a different slide from what we've had before because we use this usually to look at the age groups and to compare the infection rates across the age groups. Across all the age groups, the infection rates have fallen in the 1 week period. The 20 to 39-year-olds remain the highest group with the case rate of 306.9 per 100,000. The 0 to 19-year-olds, I think we tend to say at the moment to monitor that carefully as the children go back to school this week. We'll keep an eye on that and see what happens with the data next week, because I think the rates of testing have fallen over the school holiday period. The second highest rate of infection is with the 40 to 59-year-olds with 300 per 100,000. And those who are older, from 60 to 79 and 80 plus, remain under 200 cases per 100,000, which is again quite good to see. Our positivity rate overall remains still quite, well, I wouldn't say it's low, but it's still gone down. You're looking at a rate, a percentage of all the tests that have been taken, of all the tests I've taken, about 1 in 10 of them are positive for COVID-19, which is much better than what we had before. And concerning hospital admissions, again, it suggests that it's stable, although we know that there are still people in hospital with COVID-19 and people as well who we feel that perhaps in hospital because they haven't had their vaccines, although we know that there are those who have had their vaccines as well in hospital. When we look at the data from the previous week, the week ending the 29th, so we can look at the Champions dashboard, Habib.
Sure, yeah, I'll bring that up.
I'll just point out there, actually, the good news is that our positivity rate, though it's going down, the beauty of where we are now and why we feel a bit more assured is that the testing rates have also gone up. And this is the first time we've actually seen that happen in a long time, where the testing rates have gone up and the positivity rate has gone down. And that gives us more assurance that it's clear that as more people are testing and there are less infections being seen, that perhaps the rates of spread within the community is getting better. But as you know, all of that is subject to over the next couple of weeks as the children who remain unvaccinated and most people start to go about going back to work after the summer holidays. We need to monitor that and make sure that this is really the case, that more testing is showing us less infections and that there's perhaps less widespread COVID within the community. We've also got from this slide a total of about 263 people who are across the hospitals in the city in that weekend in the 29th of August. We know that 19 deaths were reported in that week, and it's similar, and that's what we've said earlier, to what we've been seeing previously. So the rates of hospital admissions in hospital now are slightly lower than they were earlier in the middle of July, when initially we saw the admissions going up. They're not anywhere near what we saw in January, but when you compare that to October 2020, they are kind of similar in terms of the numbers of cases of people in hospital. But it's reassuring because when you look at the actual infection rates that we're seeing now compared to last autumn in October last year, we would expect far more people in hospital than we are seeing now. And that suggests that because of the vaccination and the fact that the vaccines are primarily there to help reduce hospitalization and death from COVID-19, they are working in that respect, although we know that there are what we call breakthrough infections, or people who can still catch COVID-19 and still have symptoms, but it's less severe than it would have been if we hadn't been vaccinating so many people. So I think that's been a success for us. The next slide shows you which wards across the city based on that week ending the 29th of August, which wards were most affected by COVID-19. Again, this is subject to how much testing goes on in each ward. The top wards, as you can see, there are Sutton Trinity with 540 cases per 100,000, Northfield with 441 per 100,000, Bournville and Cottridge with 436 per 100,000, Garrett's Green with 420 per 100,000, Bartley Green with 411 per 100,000, Hythes Heath with 408 per 100,000, Druids Heath and Money Hall with 399 per 100,000, Chard End with 398 per 100,000, Longbridge and West Heath with 397 per 100,000, and Sutton Four Oaks with 393 per 100,000. As you can see, the pattern is quite widespread in that you haven't got like pockets of high rates, though down south you can see there are more dark spots there. But I think this is all subject to how much testing goes on in each ward. And what we keep an eye on for us as public health is how this compares with the city average, which is 276 or thereabout per 100,000. So it makes you realize that some wards are still facing the inequalities when it comes to rates of infection, where people are perhaps inadvertently spreading more COVID. So we are encouraging people to keep testing, because although it flags up as more rates of infection, but it does also help people to be aware of the risk and to be able to make a decision, an informed decision about whether to go out or stay at home based on the outcome of their tests, COVID test. Also to bear in mind that no test is 100% accurate. So just because you test negative on a lateral flow test does not mean you don't take that personal responsibility and still, wear a face covering, wash your hands, maintain distance where you know you're going to a crowded place with very little ventilation. And obviously still to continue to take the vaccines if they haven't yet. Everybody of every age group can have the vaccines now from the age of 16, and above. I've talked about the case rates by age already. So if we move on to the vaccine slide, unless Dr. Onye is here, or do we do the next item whilst perhaps we wait for her?
Yeah, I was going to say, yeah. Should we do the next item, Modupe?
Yeah, we can do.
Whilst we wait for Dr. Onye to come. She normally has clinic at this time, but she pops out when she has got no patients. Okay, any questions on that before we move on to the next agenda item? Any questions from anybody? Any comments? Yeah, go ahead, Pastor Turner.
Did I miss it somewhere? I don't think I was observing properly, but do you have a sort of ongoing rate, or the number of people who have got COVID at this moment in time in Birmingham? What's the kind of the picture with that at the moment?
So the data tells us how many additional cases we've had from the previous week. So up until the week ending the 29th. So from the 23rd till the 29th, we had an additional 420 cases, making that a total of 3,156 cases in that week period. Bearing in mind, the thing is, the time from when you have COVID to recovery, the incubation period is about 14 days, isn't it? And people recover over a period of time. So it's very difficult to say to you at this point in time, there are these many people. But what we do calculate are the infections that occur on a weekly basis. And we're seeing on average, I think about just under 4,000 cases every week, new cases. So incidence is about that.
Okay. Thank you, Deepa. Any other questions from anybody? Comments, observations? Now what was presented?
Good afternoon, everyone.
Good afternoon. Good afternoon, sir. Go ahead, Mr. Brooks.
I'll put myself on video so you can see who it is. I'm currently in a school at the moment, a Christian school in Birmingham. Yeah. Okay. And we've just started a new term, and you know, we've had a staff member already sort of identify a positive case of COVID. The issue for us is the lack.
We seem to have lost. Is it my connection or?
But is there anything that you could suggest as best model practices that other schools or organizations, church settings are using to encourage less invasive inspections, or is it just simply the temperature guns? Having some system that automatically just checks temperature?
Thank you very much. That's a really good question, actually. And I assume it's a secondary school you refer to?
It's both a primary and a secondary school, or through school.
Yeah, because the testing at the moment is still only recommended for the secondary school, as you know, children routinely. Within the primary school age children, if they have got a family member who's tested positive, or if they've got symptoms, then they are it's recommended that they do a PCR test. And what we know from engaging with head teachers in various schools across the city is that, as you mentioned, it varies from household to household. I've got a 14-year-old myself, and I think one of the things that's been really helpful, and the universities did this as well, is to encourage the children to understand that, you know, we're now in a better position because there are no more restrictions where, you know, there are no bubbles. But if they do get somebody coming into school who didn't get a test, who tests positive for COVID, and there's an outbreak in the school, depending on how severe, as you know, there are thresholds. So either 5 or up to 10% of the cases in a school could result in the director of public health recommending further action within that school, which could even include sending them all home. I think a lot of children are very relieved to be back in school, being able to run around in the playground with their friends. So that's usually that sort of dangling that carrot of, you don't want to go back home and do remote learning online where your Wi-Fi is playing up and all that. Yeah. That seems to be working. The other thing is I got to attend a couple of coffee mornings in some schools last term where we met with parents and they were able to voice concerns. I know something like the risk of, there was some misinformation about cancer risks from the lateral flow test, which our youth champions flagged up to us. We were able to reassure parents that there isn't any risk of you getting cancer. And I was sharing with them how my lateral flow test is now next to my toothbrush in the bathroom. I kind of know the days when I brush my teeth and then I do my test, or the, you know, so again, some of those examples through those coffee mornings with parents have really helped. I know some head teachers reached out to us and said, you know, we'd really like to do these coffee mornings, because if parents hear from either the GPs or other health professionals, they feel reassured. We've also been using our youth champions quite a lot because, again, although you ask parents to consent, I think most secondary school age children are very aware and they know what they want. So they've been able to persuade their parents to say, look, I want to have a test. So unless, again, you were talking about invasion. So if you're unable to do the throat swab, you can do just the nostril, the 2 nostrils. You swirl the cotton bud like stick about 10 seconds within each nostril. That's sufficient to do it, as if people are worried about gagging from doing the throat swab. So there are options like that we've provided, and I've had some really positive feedback from head teachers who have said, particularly where they've had outbreaks and the parents have seen this disruption, because they're the ones who then end up not being able to go to work because if their children sent to school with somebody with COVID-19. So I think those are some of the examples of things that we've seen have worked. I don't know if that helps at all. And we're very happy to offer additional support if you feel maybe somebody coming along and having a conversation with the parents in the school will help. I don't know if others on the call have any other sort of ideas or examples of things that you're aware of.
Rajiv, I've got my hand up, so if you can't see that, I'll just
go for it, Alex. Thanks.
Yeah, hi Stephen. I work as a public engagement manager within Birmingham Community Healthcare NHS, and I just wanted to recall a personal story from this morning when I dropped my son off to his school, that it goes a bit further than testing. I was one of very, very few people to still wear a mask this morning when I dropped my own son off to school. I was quite shocked by that. I'm not blaming anybody, and it is personal responsibility. But the issue for me in supermarkets where you have to go, and a school to drop a child where you have to go, it's a bit different to a pub or a restaurant where we have a choice to go to. So if somebody has a choice to go somewhere, I feel that is a place where essentially you make a personal choice, and therefore restrictions can soften, and that helps the economy, and it's a kind of thing that you can't really avoid. So if you want to go for a restaurant, you'll be aware that people don't have to wear a mask, okay? But from the perspective of Stephen and others that have congregations and big groups of people such as parents to work with, when in supermarkets and in schools people have just relaxed it, I don't see personal responsibility there. And I think there might be in Birmingham and other cities a lack of awareness about what asymptomatic actually means. The fact that you might be fine now, and it might be time to smile and give each other a hug and just to try and be positive for our children, which is a really good thing, and no one should push that away. I don't know what anyone else's reflections are on that, and it's not saying that we have to go back to more restriction. It's that actually the reason that I wear a mask is because I am on COVID wards and I am still in the NHS, so I'm doing it for hopefully the potential benefit of others, not myself. So yeah, it's just a.
Thank you for that. It'd be really helpful if you could signpost me to any marketing information or education information, that I could probably collate into a hybrid document that I could sort of share with our parents, as well as the coffee mornings and the doors and the as they come to drop off their children. Many of them, we spoke about it earlier today as a staff team, literally going around and seats, face to face, each individual parent, giving them an envelope, having a conversation, and just really reassuring them, but also encouraging them just to take part. And we're all in this together. So if there's anybody with any information, then I'll just collate it all together in some type of booklet that we could hand out to parents within a school or community setting.
Yeah, we've got some materials and resources in our team, some assets, Mr. Brooks. So I'll be more than happy to share. What I'll do is I'll connect you with my colleague who actually creates the stuff. We give her the information, she creates it into kind of like user-friendly, rather than going through, a 500-page document. She extracts out the key information. So I'll connect you with her, and then she can see information. And there's some stuff that I've got from the Gov website as well that I can directly share with you as well. Hopefully that will help you to put some stuff together.
Thank you. It's very helpful.
No, you're welcome. Outside this meeting, I'll do that. And also, Minister Maxis wants to put that she'll also contact you as well. She's got some ideas as well.
Thank you.
Okay. Any more questions or any comments regards that? Folks, I've just received a message from Dr. Okunko. Unfortunately, she's not well. She's off sick. So if it's okay with yourselves, I'll Medupe, do you want to continue with the vaccine update? Then we can move on to the next agenda item. Is that okay?
Yep, that's fine.
I'll
Can
just
do.
share- I'll
And
just
someone's asked about herd immunity as well. I think Sean
Okay, okay, you want to pick that up then?
did.
Sorry.
Well, yeah, but because that would tie in nicely with the
Yeah.
vaccine anyway. So we can do. And so how are we doing with the push for herd immunity? I think it's a big question, and not just for us here in the UK. As you know, with the vaccination program, it's a global issue because of globalization and the fact that we are all now part of a massive global village. We're all taking advantage of, as Alex was saying earlier, a bit of restrictions in lockdown to see loved ones we haven't seen for nearly 2 years. People are mixing around for work and other and leisure and other reasons. It makes it very difficult to manage the real efficacy or effectiveness of these vaccines because of primarily variants. I'm sure you've all heard more recently of another variant that's now with us that we've become aware of. So herd immunity in itself will only happen when we know that a certain proportion of the population has been vaccinated, and that vaccination offers enough protection for people not to be able to either contract or spread, actively transmit the infection, and therefore you stop ultimately the ongoing transmission of infection. As we know, the current vaccines we have done an amazingly well in reducing the number of people dying or being hospitalized with COVID. And I'll give you a bit of a heads up on some of the data we got last week on that, which you might have seen in Birmingham Live as well. What we do know though is it's still transmitting. So we're not out of the woods yet, as Alex was saying. You know, we are taking advantage of the vaccination to be able to then go out and see loved ones. But the public health advice is still to wear a mask because you might, and to continue doing your testing as often as you can, because you might still not know that you have COVID. And as we know, the booster doses are now being recommended and will soon shortly start for those who had their vaccines earlier and who are over the age of 50. Again, this is primarily because we need to be able to boost the effectiveness of these vaccines. So I think until we're confident of the effectiveness of the vaccines and in stopping ongoing transmission, because at the moment we know they're good at stopping people from going into hospital and dying, because although people are still dying and we know some, you know, a handful of people who have died have had their vaccines, but these are perhaps people whose bodies were not able to develop the level of immunity to protect them from COVID. Most healthy people who have had their vaccines are doing very well, even when they've contracted COVID. But the herd immunity will happen when we are able to see that it's able to stop spread, which is the bit that we're still working on. And we are saying that the public health measures are not just vaccines, and the vaccines in themselves are not a magic bullet. So it's vaccines in addition to everything else, washing your hands, wearing your face coverings, doing your testing and being vigilant, that will help us to get to the point of wider population or community immunity, as we call it as well. With regards to the vaccination update, as you can see on the screen, we've started to vaccinate the 16 to 17-year-olds, and we're doing well and making progress on that front. We are doing a lot of work in the community, working with the universities and other groups who work with the young age group to try and encourage them and to understand what the barriers might be to them taking the vaccines. I know things like fertility and of those inflammatory disease came up, and we've been sharing some insight and facts that we've received from the literature in a simple format to help people to make an informed choice about this. And we continue to encourage anybody who has any doubts to speak to a trusted professional, a GP or a doctor or somebody that is well informed, and not to rely on stuff that's being spread on social media, some of which can be misleading. The uptake in our NHS and social care workers right at the bottom has also gone up, which is really reassuring as the deadline for social care is looming. I think from the 11th of November, anybody who works in social care who has not had their vaccine is not going to be able to work. and you have to have had 2 doses and been fully vaccinated. So we're really doing a lot of work. Our DPH was met with some social care staff the other week, I think about 2 weeks ago, and listened to their questions and tried to reassure people about taking the vaccines. And so we are working hard to try and support them. With those who are clinically extremely vulnerable, for those children who are aged 12 to 15, who are clinically extremely vulnerable, they've been prioritized for the vaccines. And this week, a lot of them would have had a letter or a call from their GP or the PCNs, the primary care networks, inviting them to have their vaccine. So that is going on as well. And so these are the priorities groups at the moment for the vaccination. And this next phase really is to continue to mop up those people on this priority list who have not had their vaccines, to prepare for the booster doses for those who had it already and who need the booster, and to ensure that the 12 to 15-year-olds who are clinically extremely vulnerable or who might be from a household with vulnerable adults are also able to receive their vaccines. And we're working closely with the NHS to ensure that that's being progressed. And the next slide, the last slide, just offers you again an overview for each ward, the data we received up until that week ending the 30th, well, not the week, but up until the end of August. As you can see there, we still have a handful of, well, not handful, quite a few wards with uptake below 60%. And those wards are the ones that we've talked about quite frequently on these calls. And we will continue to work with groups within the communities and the NHS to try and either take the vaccines to people or answer questions that people may have or concerns they may have about taking the vaccines. I just wanted to share, I think Alex has got his hand up, some information we received as well, because people have asked us before at these meetings about hospital admissions and COVID-19 vaccination. So we had a report that was shared and an update actually went into Birmingham Live. Between May and August, we had about 530 people admitted in hospital. About 67 of these people were in critical care and about 463 were non-critical. Of all those who were in hospital, I think most of them were the highest number. Actually, I wouldn't say most of them, but the highest number were aged from 35 to 44. And majority, about 65%, were under the age of 64 years, compared to 34% over the age of 65. So you can see that we're seeing a much younger cohort or group of people being admitted to hospital with COVID-19. And we were also able to see that about 37% of the patients in hospital had completed their 2 doses, whilst about 54% of them had not been vaccinated at all. So this data obviously is subject to a bit more cleansing. I think I promised last time that we'll be able to offer you some insight, but from what we can see and from the conversations that we've had with NHS professionals and other people within the system, it's so important for people to have confidence in the vaccines, but also it's got to be that we're not necessarily forcing people, but we're giving them the information they need to have an informed choice and for them to talk to a trusted professional. But our biggest worry is that a lot of the people in admission in hospital are younger people compared to what we saw at the beginning of the pandemic. And so that really makes us think that we need to do a lot more work with our younger population. Across the ethnic groups, it varies. I think mainly white ethnic and Pakistani groups, or those who didn't state the ethnicity, were those we saw in hospital. And so we are trying to continue to do some more work. We're going to be putting out some campaign material over the next couple of weeks using trusted voices within the community to answer some of the questions that people have been asking us through conversations like these faith meetings and other meetings and engagement meetings we've had with our champions and other people. So do continue to share those questions and concerns within your congregations with Habib so that we can put the information out there. And what we'll do is we'll share the content with you in a way that's easy for you to then pass that on to members of your congregation. And just to reassure people, as we continue to monitor the situation over the next few weeks. Thank you.
Before we go to Alex, there's a couple of questions, if we can just take those. The first question is from Pastor Turner. Do you know if or when boosters or vaccines will be targeted specifically at the newer variants?
So what we know about variants and the vaccines is that the emerging evidence, again, this is a constantly moving beast, is that the good news is it appears that the current vaccines that we're using, and it's not just in the UK, worldwide, are working against known variants of COVID-19 because it's that spike protein they still manage to recognize and fight. What we do know is that, for example, the Pfizer vaccine has a better effectiveness against the Delta variant, we are told, compared to the Oxford vaccine. And that's what the emerging evidence is saying. But bear in mind, it doesn't mean that AstraZeneca doesn't work against it. It's just what they've observed. But there are what we call confounding factors, the factors that often you cannot control. For example, we used AstraZeneca quite a lot on elderly people who were not going to be able to produce enough immune response anyway. So perhaps the reason why the Pfizer vaccine or the mRNA were more effective was because they were used more on the younger generation who were going to build up enough immunity. So I haven't read more recent papers because I know that there have been lots more papers published about the effectiveness of the vaccines, but the overall view we have is that the vaccines do what they say on the packaging, which is they're stopping people from ending up dead or in hospital. We know that because if we're recording 25 to 30,000 new cases every day, and we're seeing 80 deaths, if you compare that to what we saw last year, we should be seeing more people dying from COVID-19. And the data and the stats from the hospital admissions, which we need to look at over a longer period of time, suggest that we are doing well. And so for us, the concern is the younger generation and trying to get more younger people to trust these vaccines and to take them, because not only are they going to end up in hospital, but they will then be inadvertently spreading, like Alex was saying earlier, to other people who are vulnerable, who have taken the vaccine, who are not necessarily protected fully from getting COVID. So we need to really see that sort of social responsibility, and that need to be almost like your brother's keeper is not what we're saying now going forward.
The next question is from Mr. Brooks. Can we confirm hospitalization percentage of those hospitalized with or without vaccination?
Yeah, so the data which we have, again, bear in mind, so this is not yet validated fully, but it suggests that those who have not had the vaccine were about 2/3, so about 55% compared to about 35% who had their 2 doses. And it was out of 500, just about 530 people in hospital during that period.
Okay, thank you. And there's an analysis put in the comment in terms of longevity in Israel of the Pfizer. Will be a good topic to have a presentation on. Maybe we can get information.
We can definitely do that. I think we can look into that and see if Justin can come along and do that, because I think it's at the moment it's up in the air, isn't it, Alex, in terms of those vaccines and the longevity, because everyone's won, even the WHO said it the other day, because every country's rules around vaccination varies. In Israel, they're vaccinating 12 to 15-year-olds. We still haven't done that yet. So we have to be able to look at the data broadly.
The point is about the sharing of news and information, and as soon as I see an article which is potentially a little bit ambiguous, it's good to jump in, because I know that I was with a few friends of mine in a Somali community forum in West Bromwich. And some of the questions that they are getting from their residents at the moment is, will I get a booster if I'm 35, or is it going to be for over 50? So really, really interesting questions. But also, is it going to be a flu jab? You know, is it going to be like an annual? Also, can you have it on the same day as your flu jab? Because there's a lot of people saying that people are going to have one in one arm, one in the other arm. So it's just because these issues are being discussed in my community forums, I think it's really good to strike while the iron's hot and actually try to, even though the strategy might not be set, it still helps everyone on this call to know those kind of it's a bit like, you know, those of you that have been around NHS for a long time know that we do the annual flu Mythbusters. Like when people say, oh, the flu jab can give you flu, and you'll have a really good statement that explains why it doesn't give you flu. You know, it reduces your immunity, so you might feel, you know, cold-like symptoms for 2 or 3 days after having it. It's that sort of thing that we wouldn't, it would just become business as usual for COVID vaccinations, I'm sure.
Yeah, I mean, we can definitely look into that and try and pull together a session and get Justin as well involved. I think one other thing to bear in mind when people talk about Israel is that, and that's what I mentioned earlier about the variations, many countries are not just giving vaccines, they also then putting in either lockdown or other restrictions, which can in a way skew what the, you know, your, as I mentioned, confounding earlier, as we call it, it's very hard for you to understand what really caused that reduction in transmission. Was it the vaccine or the fact that you then imposed a law saying to everybody, you must wear a face mask, which you mentioned earlier, we're not doing. And even human behavior, because even if you have a law that says wear a face mask, as you know, the population in the UK is different from the population in Israel, in China, and other parts of the world. Compliance, the fact that you'll have a face mask law and then lots of exceptions, like 20 list of reasons why it's okay not to wear a face mask. All of these have an impact. So, and we all use different vaccines as well, which again, so a lot of what the WHO is saying at the moment is this is a moving beast. This is something we're observing, because what you're finding is because the approaches we're all taking worldwide are different. The combination of vaccines and all the other public health measures are the things that they feel for now they can recommend. And I think what we need to be telling our communities is to be reassured that where we are now compared to where we were last year, because we have got the baseline of last year when we had no vaccines and we had very little testing. The game changer now is the vaccination and the fact that we can all test. You know, we all have test kits available to us. We don't know how long they're going to be there for, but we can all take responsibility, check ourselves out before we go. It's a bit like with HIV and what they say about unprotected sex. You know, you got the ability to stop yourself being a super spreader of an infectious disease. And that's where we are now with this. But definitely we can do the comparisons, and we can look to organize a session where we look at where we are compared to other countries. But with that caveat that every country is vaccinating, but also putting in either lockdown or additional protection, which tells us that for now, although the rules have been lifted completely, it's down to us as individuals to please continue to protect one another by testing, by wearing our face mask when we can, and washing our hands. And these are the things we want to teach the children in school as well, to keep washing their hands as they come back to school. It's the simple things that really do work.
Yeah, agreed. And Bishop Richards also put down there in terms of how each governments and countries are different. It's very difficult for us to make adequate or accurate comparisons between country to country. You know, how Israel monitor and control is different to how the UK do it, to how other countries, you know, globally do it as well. So it's very difficult. Thank you for that, Bishop. Okay, I'm just conscious. Yeah, go ahead, Pastor Turner. You actually get your hand up. Go on.
Just really, when you put up the list of the wards where less than 60% had received a vaccination, it just struck me, these are seen to be inner city wards, high density, highly diverse, high deprivation. What else did I write down? Yeah, those are all, it's like they represent a lot of people crammed into a small space. And it just makes me feel that when we're taking precautions as a church community, everybody who's coming, they feel like they're just like the rest of the city. You know, there's lots of people have been vaccinated, so there's not too much of a risk. But actually, where we are in Handsworth, you're saying that only 49% of people have actually had the vaccination. Was that both doses or?
Yeah, so that data will be the overall based on all the doses. I mean, one other thing to bear in mind is we know some wards are much younger than others. And so in some instances, it could be that they weren't eligible yet, or There are now wards where the younger generation are a bit more anxious because of things like the myocarditis, the inflammatory heart disease and infertility, all those issues that older people probably didn't worry about in wards with older people. But you're right, all those environmental factors and the underlying social determinants, housing, education, deprivation, these are the things that really make us very worried. And because the rules are no longer there to keep people still, and stop people from mixing, I think we said this before when we got to a point where we were coming out of step 4 and we thought, okay, we're having all these meetings. What's the point of these meetings now? Because there's not much of a COVID update. But the point of these meetings now is this is the time when we desperately need yourselves as community leaders to really help really hone in and stress the importance of the risks to people, because it's now down to individual risks. I mean, I had an email from a school head teacher asking me about a pregnant teacher coming into school and the risk assessment around that. What do we do? And I said, well, you're going to have to sit with this woman and she has to have a conversation through her clinician about the risks to her, because now there isn't a law that says you can work from home or you're exempt. All of that is now being lifted. So these are the real stories and the realities that people are facing on a day-to-day basis. And what we need to be able to do is understand that we're all, as you mentioned, at different stages. Some of these people, English is not their first language. Perhaps all the information we've been putting out there is not accessible to them, and they get confused, as Alex said, because they go out and no one's wearing a face mask. So they're thinking, why do we need to wear a face mask? Do we need to break it down to them differently? Do we need to have a few more events explaining, and do we need more people within those communities who have had COVID or who have changed their minds and had the vaccine because of some other reason, sharing their stories with them, because perhaps that would be more credible and trusted than, my voice or Dr. Onye's voice. So these are the issues and the things that we need to be thinking about, working with you all. And we need to address these quite urgently. You're right, those numbers are quite low and it's worrying in those communities. Yeah, I've seen the email, the comment as well. You're on mute, Habib. So the announcement that was made on, I think it was Friday or Saturday, by the JCVI, I think it wasn't necessarily due to just the potential risk. Although remember, just like the blood clotting, the heart inflammation risk is a very rare event. So just like we mentioned before, there are more events of blood clotting. It's a higher risk of blood clotting from the contraceptive pill, from flying long distance and all that, than it is from taking the COVID vaccine. There are very, very rare events of heart inflammation from the mRNA vaccines, which is the vaccine that they would recommend for the younger cohort anyway. But what the JCVI also said was that when they looked at the evidence for vaccinating children, they didn't think the benefits, this is what I mean, from vaccination was showed that they didn't see what they called a bigger benefit from vaccination than from allowing the children anyway to get COVID. Now, don't get me wrong, because we've been talking about long COVID, which we still don't know about. We're learning about that. Long COVID is real. People who report long COVID symptoms, and I've spoken to 1 or 2 people directly myself, have said it's very debilitating. But the JCVI have to look at the bigger picture. They need to look at not just children, but they also need to look at the wider society. And at the point we're at now, they feel that the risk to children is very minimal, because when children have COVID, they barely have any symptoms. They recover very quickly and they're back to normal compared to the adults. So they have to make a judgment, and they have to look at the analysis of the evidence that has emerged. That very few children have been admitted, for example, to hospital or died. I think across the country, about less than 30 children were told died from COVID-19. So these are the overall. So it wasn't just the inflammatory disease. They looked at several factors, and then they had to look at a risk-benefit analysis and decided that the benefit of vaccination for that age group was not sufficient to ask you to vaccinate all of them when you compare that to the risk of what happens when a child is exposed to COVID. So that's the current situation. Whether that's going to change, over the next couple of weeks. We don't know. We're waiting to find out what their final announcement will be. But children who are aged 12 to 15, who are clinically extremely vulnerable, or who are part of a household with somebody who is clinically extremely vulnerable, or who is at severe risk of dying or being hospitalized from COVID, will be offered and are being offered the vaccine at the moment. And so those are some of the things that, again, for us as public health experts, we have to manage alongside the announcement. We have to manage the expectations of lots of head teachers. Just last week, we're asking Justin and I about vaccinating the 12 to 15-year-olds, and then the announcement went out on Saturday. So we are keeping an eye on that. And as we promised, we will always keep you up to date with the most current information and facts from credible sources, not just the media. Go on, Alex.
So some of you might be aware that there is a sickle cell and thalassemia service in Birmingham, and it's actually run by Birmingham Community Healthcare, my colleague Laurie, in Handsworth actually. And the article does also say that some children, you know, the most vulnerable, especially children with sickle cell, may be offered or should be given the choice whether the parents want to offer the vaccine, because some of the children with sickle cell have become the most ill if they've also had COVID, because obviously the complications that can occur. So I think for this meeting as well, looking at sickle cell demographic data, it might be mindful that you explore that in your research, because parents may ask the question, and it's good to know. I think that's another one for that meeting potentially.
That's a really good point. Yeah, I think the sickle cell definitely is a good one. Did Ms. Grant have your hand up?
I didn't see it. Ms. Grant, do you have your hand up?
No, not me.
Okay.
I'm just conscious of time, colleagues. We need to move on. Artie's been waiting patiently. Artie, over to you. Artie's a colleague from BSOL CCG from the suicide prevention team. Artie, over to you.
Thank you. Hi, everybody. Thank you for having me here today. I wanted to just do a quick presentation on suicide prevention and some of the work that I'm doing, because we actually have World Suicide Prevention Day on Friday, which many of you may be aware of, or you might be marking in certain ways. So September the 10th every year is always World Suicide Prevention Day. And I wanted to just share some of the things that we can do, which hopefully I should be able to do. Hopefully you all should be able to see my screen. Can you see my screen?
Yeah. Yes.
Everybody can see that okay?
Yes.
Perfect. So I am aware that I've met some of you before, but just in case people have forgotten or people don't know who I am, my name is Artie, and I'm the Suicide Prevention Programme Manager working across Birmingham and Solihull Public Health. And my main role really is to work in suicide prevention and look at, as a community, all ages across Birmingham and Solihull, how we can help to prevent suicide, you know, from an organisation, structurally, strategically, but also on the ground as well, as much as we can do to prevent that. This is probably going to be a bit of a speedy presentation, so I apologise if it might be a bit quick, but I just wanted to talk through some of the things that often people think about when it comes to suicide that might be true or they might not be. So one of the things that we get a lot is if somebody's talking about suicide, then there's nothing that we can do about it. And actually that is a myth, because what we find is that there is always something that can be done by anybody when anybody comes into contact with somebody who's in distress. And we can liken it to somebody just being in distress. You can listen to them, you can signpost them to services, you can maybe raise your concerns with another colleague, maybe who's a bit more senior, and actually maybe get them to have the conversation. And if you've got the skills, you can also do an intervention. Nobody's saying that if somebody's in distress, you have to solve their problems or you have to do things with them. It's about actually being able to maybe just listen to them and maybe just appropriately signpost, or maybe if you've got concerns, share that with somebody within the organisation so that they can help support you. What we would say is that if somebody's talking about suicide, then it's actually a really, really good sign, because what it means is they want help and they want support and they want you to help them get that, because they might not understand or know where to actually start. So if they're talking about it, it's actually a really, really good place to be. The other one that we get a lot, or people think a lot, is that talking about suicide is actually a bad idea, as it could give someone the idea, and this is actually really common. I've been working in suicide prevention now for over 5 years, and we still get this a lot from professionals, where they say that they don't want to say the word or they don't want to have any encouragement to that individual. And actually there's no research or evidence in any way to support that if you say the word suicide to someone or ask them the question, that they're actually going to think, oh, that's a really good idea, because it's quite likely they've already thought about it. In fact, what the research tells us is that it's really important that we talk about suicide, and it's really important that we ask the question, or we share taking your own life, ending your life, thinking about suicide. And the main reason that is because for an individual to talk about what's distressing them to the point that they've thought about suicide, it can actually be incredibly difficult. So if I was to say to someone who is in distress, you know, you've spoken about a lot today and you've talked about wanting to end the pain, and it makes me wonder, have you thought about ending your life? What I'm telling that person is I'm okay to have this conversation with you and there'll be no judgment from me, and I'll be here to support you. So it's actually almost gives them permission to be able to talk about it. So talking about it's a really good thing. Another one we tend to get is that you have to be mentally ill to think about suicide. Now, for some people, there is mental illness that is diagnosed, and they are known to services when they go on to think about suicide or go on to take their own life, but for a lot there isn't. And that doesn't mean that something could have been there that need to have been diagnosed, but we also know that there's a lot of social and more economic factors as well, such as things around poverty, debt, relationship breakdown, that can actually contribute to people thinking about suicide. And then finally in here, people who are suicidal want to die. And that's another really big one as well. And it kind of links in with the first one, where people often think, well, if someone's suicidal, there's nothing I can do about it. But actually how we can frame this is actually thinking that if somebody is suicidal, they actually just feel that they have no other choice and all they want is for the pain to end. And when we think about it in those terms, there might be something we can do to help them alleviate some of the symptoms of their pain, whatever that is, that's actually happening for them. So it's about ending the pain rather than actually wanting to die. So we would say overall, all of these are myths. The other thing to think about with language with suicide is actually how we talk about it and how we talk to somebody who has either lost someone to suicide or somebody who might be thinking about it currently. So we're going to go through unhelpful language for now. So the first thing that we say is rather unhelpful, and we want to stop people from using as much as possible, is committed suicide. And it's a very, very common term. I used to say it all the time before I started working in suicide prevention, and you know, a lot of the news outlets use it, a lot of the media uses it. It's a very common term to use, but it actually refers to a time when suicide was a crime. Suicide was a crime in this country up until 1961, and we use the term committed when we talk about committing a felony, committing a robbery, committing arson. It always refers to generally around a crime. So we want to try to get away from some of that language because it's quite old school and it's not really relevant to how we talk about suicide now. Another way that we talk about suicide is talking about failed. It might sound a bit cringy and it might sound that it might be unexpected, but I actually hear that a lot more in my line of work than I would like to. So we get failed suicide attempt, we get successfully took their own life or was successful in taking their own life. And sadly, they're really, really common. And what we're saying to people is really putting value-based judgments on what's happening. So you failed to take your own life. You can't even do that right. That's the message that they might be getting, that we're a failure in that. And you know, it's really got that judgment in that. They successfully took their own life. Success is something to be celebrated, and we don't really want to have those terms when it comes to somebody who's gone on to take their own life. And then the other terms that we get are things that people say, well, it's a cry for help and it's attention seeking. And actually, interestingly, we get this a lot with our young people. We've done quite a lot of work in schools and in colleges and university settings and young people settings where a lot of the professionals around them might say, actually, well, it's the 12th time that they talked about suicide, so they're clearly not going to do it, and it's just a cry for help, or it's just attention seeking. Now, I want to acknowledge how difficult it is in those settings to have the patience, especially if it is the 12th or 13th time somebody has threatened to take their own life. But what we can absolutely say is we don't know if that's the 12th or 13th time somebody has said it. We don't know that they're not going to. There's no guarantee that they're not. And I often want to say about these terms, if somebody's crying for help, what do? You might go and help them and find out what they need. And if somebody's attention seeking, then we might need to go and see what they need. So it's about really changing some of the negative connotations associated with some of this language that we use. And now if we move on to helpful, what are things that we can say? So we need to stay away from any judgment-based language or any value-based judgment language. So completed suicide, so somebody went on to take their own life, completed, that's something we can say. They've attempted suicide, you know, where we've got failed kind of on the other side. So we're going to try to keep some of that judgment out of it. And For some people, they may not be comfortable actually saying the word suicide itself. So we might want to say things around ending your life or taking your life, which are still terms that people really understand what you're trying to say as well within that. And really, the whole point about language and what we want to get to is just to be really simple in the language that you're using when you're talking to someone who's in distress, and be really direct about what you mean. Make it clear. Make it clear what you're saying, make it clear what you're talking about, and then it's up to them to tell you whether it's a yes or a no, and then based on that, you can move forward in that conversation. I know that was fairly quick, but I hope that helps a little bit on the language side of things. What I want to share with you today is a few services as well that you can signpost to if you have got somebody who's in distress, or if you actually just need a bit of advice. And these are services that you can also contact and speak to as well. So we have the Mind Helpline, which many of you are aware of, available across Birmingham and Solihull, 24 hours for adults and young people. So you can call them as a professional if you need any help and advice or support, and you can also direct other people to go to them as well. Now, the thing to mention about the Mind Helpline is they do have access to Language Line. So if, of course, you do have somebody who is more fluent in a different language that's English, and actually they'd be more comfortable talking in that language, you can request that. You can request that on the helpline, and they can absolutely use Language Line to help get a translator in to have that conversation. So we're trying to overcome some of the barriers that people might seek in seeking support. We've also got the bereavement service, which if some of you were here in July, myself and a colleague did a presentation on, and the bereavement service is for anyone, whether they've been affected by any type of bereavement, including suicide, personally or professionally. And there are various languages available by volunteers who currently work in the bereavement service, but there's also additional that can be requested as well. And then finally, there's the waiting room, which I'm sure many of you are aware of, and it's a website that details all health and wellbeing services across Birmingham and Solihull. So if you don't know about it, it's definitely really, really useful to have as a tab, and maybe bookmark that tab so then it's got everything that you need there. And then finally, what I kind of want to share is a practical thing for you to take away. I mentioned that World Suicide Prevention Day is the 10th of September, and the theme is creating hope through action. And what I want to set for yourselves today is an action to take away. And that is to complete the Zero Suicide Alliance 20 to 30 minute online free training. It's an interactive training that covers 3 scenarios: a family scenario, a work scenario, and a stranger scenario. It talks about how we spot the signs, how we appropriately and sensitively use language, and it talks about signposting as well. I have a link that I'm going to share with Habib, if that's okay with you, Habib, and then you can share with everybody.
Yeah, sure.
So everybody can actually access this locally. And it is a very, it's the first step in doing any type of suicide awareness training. But if you haven't had any before, or if you need a bit of a refresher, please share this as widely as possible. The more people we can get comfortable talking about this and being able to share this is really important, and it will absolutely help us to go on to save lives. So that's it from me today. I'm sorry that it was a bit, sorry, let me just stop sharing my screen. Stop sharing. So it was a bit quick. I don't know if I've got any time for questions, but I'm happy to put my email address in and kind of share anything around. But hopefully, if I can ask you all just to complete the training and maybe share that with colleagues, I think that would be really brilliant, and share as wide as possible as you can, as we want to get as many people completing this training as possible. Thank you for your time today.
Thank you, Arti. That was very comprehensive. Is it? I'll just ask, would it be possible to share that presentation? If you share that with me, I can share it with the group. That when you send me
I
that
can,
link.
absolutely. But what I would say is it might be helpful for people to maybe watch it or listen to it alongside maybe watching this if they haven't attended.
Yeah.
Because then obviously I've been able to explain some of the things. I'm also presenting it on Monday as well at the Interfaith meeting. So I can send it after that, because I believe for some people they may be attending that meeting as well, and I'll share everything after.
That's fine. Yeah, that's fine. Yeah. Do that after that, please. Yeah, that's fine. Any questions for Arti from anybody? No questions. Thank you for that. Thank you, Arti, and thank you for your patience.
Thank you for having me.
No, it's not a problem whatsoever. Any other business from anybody else? Any other colleagues? No. If there's no other business, the date for our next meeting is in a fortnight time, which is Tuesday, the 21st of September, if my maths is right, at 1 p.m. And thank you very much, colleagues, for attending or joining today's call. If there's anything else that people would like to raise after the meeting, don't wait until the 21st. Please do email me or contact me. Most of you got my contact details. Mr. Brooks, I will connect you with my colleague in public health, the materials and resources for your school. If there's nothing else, everybody stay safe. Thank you very much. See you soon. Thank you. Bye-bye.
Thank you. Thank you.